suffering from BPH, which is benign prostatic hyperplasia. I'll just hold it. Okay. We'll see if that works. So benign prostatic hyperplasia. We'll talk about that in a little bit. So the urge, and the word is for micturition, or micturate, which means to urinate. Can you see that okay? Yeah, okay. So urge for micturition occurs at approximately 350 milliliters. You're going to see a bit of a range in your book. It'll say from like 200 to 250 or 300 to 350. He won't give you numbers so close that you can't decide. Okay, so knowing about 300 to 350 is a good place to be. So that's urge to micturition, which is the same thing as urination, releasing the contents. So then we should talk about how that actually happens. So let's use green. Okay. So for micturition, we have our urinary bladder. And I don't know if you guys remember, but you have two sphincters to control the outflow of urine. So we have our internal sphincter. So the internal sphincter, and not drawn to scale or drawn accurately, we have the external sphincter. Okay. And here in orange is a really important thing. We have our detrusor muscle. So urination in of itself is a parasympathetic process. And if you guys remember, sympathetic is fight or flight, and parasympathetic is rest and digest. Now, your body knows what it's doing. When you're in flee or fight mode, your body does not want to spontaneously release urine. That's bad for many reasons. But to prevent that, we actually have the detrusor muscle be innervated by parasympathetic nerves. That way, once a human is calm and in a safe situation, they can release the contents of the urinary bladder. To prevent anything from spontaneously leaking, which is also called urinary incontinence, the internal urethral sphincter is innervated by autonomic nerves, specifically sympathetic nerves. Now, we've discussed in the past that sphincters are innervated by sympathetic nerves to give them tone, so the sphincter has tenacity. This will prevent any contents from being released, like we talked about our lower esophageal sphincter and acid reflux. When we have parasympathetic activation, that came out weird, we have sympathetic inhibition. So our detrusor muscle is contracting, and our sympathetic internal urethral sphincter is being released because it is inhibiting the sympathetic innervation. Does that make sense? Okay, so then we can have the release. As opposed to when you have sympathetic stimulation in a fight or flight situation, the urethral sphincter will be closed. Now our external urethral sphincter is cool. That one has somatic innervation like the pudendal nerve. And that actually gives you the ability to choose when you urinate. So this is somatic innervation. Okay. So that's good stuff. Good stuff. Okay. So we've discussed what we need to know about the bladder. I don't know if you're going to be tested on this in lecture. It's more of a lab thing, but just so you guys know, that triangle down here of smooth muscle, there's no rugae. It's called the trigon. And it's just an important landmark. Your ureter's open about here. And I've never seen a question come up about the trigon, but it's good to know where and what it is. So moving on to some... Yeah, on the trigon there are no rugae. It's smooth. Okay. So what'll happen if I keep screaming? Will it just be really loud? Okay. So I'm just gonna have to keep screaming at you guys. I hope that's cool. Okay. So we talked about our prostate having acidic secretions. We're gonna talk a little bit more about that later. What I actually want to get into is the layers of this prostate. Okay. So we're gonna start here. This is a urethra. And it has to be a male urethra because we have a prostate gland, which is only in a male. We don't have a prostate in females. So first, kind of a double lobular shape. You have the transitional zone. Transitional zone is a very small amount of the mass of the prostate. It's about 5%, really minimal. Continuing outwards, surrounding that zone. It's kind of lopsided, so I could fit that in there. In the orange, we have the central zone. The central zone, a little bit more. This makes up 20 to 25%. I think your book says 20. So it's about a quarter to a fifth of the prostate's mass. Now the big one we really need to know is the largest zone. And this is pretty blown out of proportion, but that's okay. It's just to get my point across. And this one here is called the peripheral zone. Now, it's important to know, just because the peripheral zone actually serves to have about 80% of prostatic cancers. So 80% of cancers in the prostate are in this zone. Now, like we see with cancers of other areas, cancers of the prostate, along with some other issues, can actually cause the prostate to enlarge. One of those conditions is BPH, benign prostatic hyperplasia. There's multiple causes of it. There's little to no chance you're going to be asked for a cause of BPH. it's more important to know what happens with BPH. So with BPH, you have enlargement, and the prostate itself becomes a little fibrous, becomes very tough. It has a hard time secreting its secretions. So with BPH, you can have enlargement, and a symptom that a lot of people are familiar with is difficulty urinating. Now, when you do a prostate exam, they do it rectally, so the doctor has to lubricate the finger. You can actually feel the prostate through the rectum, just due to the location. So that's another thing to know. If you were to ask how to assess a patient that you suspect has BPH, you have to do an intrarectal exam of the prostate. Okay, so I think that's everything I wanted to tell you guys about the prostate. And we're going to move on to the interesting aspects of the female pelvis. Okay. So. Oh, it was far away. Okay. So we're going to discuss the broad ligament. So we know the broad ligament is this ligamentous portion of the peritoneum that actually sits on top of the uterus, the ovaries, the rectum, and all that good stuff. That's the bottom portion of the peritoneum. It's important to know the contents and what the broad ligament actually touches. Now, before I get started, broad ligament has multiple names. And like I say, whenever you have something with multiple names, you need to know every name. So we have the broad ligament, ligamentum, latum, and the other one is, say it again? Oh yeah, that's true, uteri. I've never heard anyone actually say the uteri portion, so that always throws me off guard. And I'm blanking on the last one. Yeah, thank you. You can also call it the mesometrium. All right, thank you for that. Typically, more often, you're going to see broad ligament or ligamentum latum. Broad ligament's most common. So for our broad ligament, we need to know the contents. Now, in your book, it's listed out as 10 various contents, but for the sake of a mnemonic that I actually heard a couple years ago, I like to break it up into 12. And here's this mnemonic. Okay. So we have O-U-T, out, goes, puff, with 2 P's. When I used to say this, I used to say out goes puff puff, so I wouldn't forget. Okay. So this can kind of help us lay out our contents of the broad ligament. So first things first, we have the ovarian, nerve, artery, and vein. So I like to call those nav. We have the ovarian nav. We also have the uterine, nerve, artery, and vein. Here for the T, we have our transverse. It's also called the cardinal ligament. It's one of the main ligaments for ligamental support of the uterus. You have different types of support, being passive, like the 90-degree angle of the uterus over the urinary bladder. You have mechanical, being the pelvic diaphragm, and then you have ligamentum, being the transverse or cardinal ligament. Okay. Yeah, those are supports of the uterus. Do you guys want me to repeat that? Okay, so you have 3 types of support for the uterus. You have passive support, which is the 90-degree bend of the uterus over the urinary bladder. You have mechanical support, which is the muscular support provided by the pelvic diaphragm. And then you have ligamental support, which is the transverse and cardinal ligament. You have some minor ligaments assisting as well. This is the main one we like to discuss. Okay. So now we're looking at G. We go to our Gartner's duct. Now more of our ligaments. We have the ovarian ligament. Not to be confused with this S down here. I'm going to skip ahead and do it real quick, which is the suspensory ligament. Suspensory ligament serves to suspend the ovaries up above the uterus, kind of like this, attached to the abdominal wall, while the ovarian ligament serves to tether the ovaries to the uterus and just that area. Okay, so now we have our E, which is epiphyron. We have our P, which we have peripheron. And the other E is for parts of the ovary. Now, the entire ovary is not covered by the broad ligament so that we can still have release of the egg cells to be captured by the infundibulum. If the entire ovary were to be covered, the infundibulum would not be able to receive the egg. And it's for this reason that the peritoneal cavity in a female is open, because of the opening of the fallopian tubes to receive the egg. So that's another thing to note too. So we have our next U. We have our ureters. Ureters are covered by the broad ligament, at least in portion. All right, so our two Fs. We have our fallopian tubes. And we have fat / AER? No. Areolar tissue. Areolar tissue is another way to say fatty tissue. Okay. So while we're in this area, we're going to discuss the fallopian tubes a little bit more. So the fallopian tubes, we've discussed, serve to transmit the egg to the uterus. Now, fallopian tubes are also important because this is where fertilization must occur. So fertilization occurs in what part of the fallopian tube? Do you guys remember? Nice, in the ampulla. Ampulla, I think, is 2 L's. In the ampulla. If fertilization does not occur in the ampulla, or ampulla, however you say it, blue for clinical, we could potentially have ectopic pregnancies or miscarriage. I think that's how you spell carriage. So if fertilization occurs too soon, and rather than in the ampulla, occurs like near the fimbriae or near the isthmus, the egg can actually implant on the peritoneum. Later, we're going to discuss more of the attributes of the uterus that allow for implantation, but keep in mind that the peritoneum was a very vascular structure. So the egg can implant and actually use those arteries for the necessary blood supply. So that's an ectopic pregnancy. You can also have a miscarriage because the fertilization does not happen soon enough. Let's say it happens more towards the end of the fallopian tube or actually in the uterus. The timing won't be accurate for implantation to occur. We're going to talk a little bit more about that when we get to the menstrual cycle, but I just want you guys to have that in your head before then. Okay. Another important thing to know about the fallopian tubes is salpingitis. Salpingitis is infection and inflammation of the salpinx, which just means fallopian tubes. So inflammation of fallopian tube epithelium, which I cover the epithelium of almost all the organs in this block in a different video. It's the one I did like 2 or 3 semesters ago. So keep a lookout for that. Epithelium has been asked in the past, but not as much recently. So make sure you look that over. However, fallopian tube might be good to know because it relates to salpingitis. So inflammation of the fallopian tube epithelium, which is simple, ciliated, columnar. And this serves to produce the current that actually carries the egg to the uterus. So if we have inflammation of this epithelium, we can't have that current being produced. We also don't have a pathway for the egg to travel to the uterus. So salpingitis. Yeah, sure, I'll give us a shot. Is this like the 4th shot, 5th shot? All right, we'll make it work. So, where were we? All right, simple ciliated columnar epithelium in the fallopian tubes. So that serves to create the current for the egg to actually be carried to the uterus. That will allow the implantation to occur. If you have inflammation of that epithelium, the egg will either not be able to reach the uterus, which would prevent fertilization, which can cause infertility. There's no pregnancy there. Salpingitis can also lead to PID, or pelvic inflammatory diseases, which will irritate the peritoneum, and that goes into block 4, like we had previously discussed, where if you have increased fluid secretion of the peritoneum in a female, while she's standing up, that will accumulate in the deepest pouch, which is the cul-de-sac. Do you guys remember all that stuff? Awesome, good. So we need to keep that in mind. While we're talking about the uterus, I actually want to grab a picture to show you guys. I'll focus a little more on pictures towards the end of the review. However, in the past, this has been on the exam, so it's good to know. It's also good to know if you plan to pursue any further same class. This gets brought back again. So here you can see we have our uterine cavity, which is just in here. We took a transection of the endometrial layer, which is the most inner layer of the uterus, and that layer itself has multiple layers. So the first layer is the stratum compactum. That is the most apical layer. Apical means on the surface. Yeah? This is figure 5-13 on page 339 in the 3rd edition. Okay, so that's the apical layer, the stratum compactum. And I remember that because that layer gets compacted frequently with menstruation and the shedding of these uterine layers. Then we have the stratum spongiosum, much like in the parts of the male penis. The stratum spongiosum is the largest portion. And then we have the basal layer. That one's pretty easy, it's at the base, right? Then we have our myometrium. Myometrium is the muscular tissue of the uterus. It's the thickest layer. And that serves as like our foundation for these layers. There we go. Okay. So these are layers of the uterus. It comes up every so often. I remember he mentioned it once to know the picture. So I wanted to review it with you guys so you guys were aware of it. We're still talking about this. Zoom out. Another pathology we discussed is habitual abortion. There are several things that can cause habitual abortions. this just refers to at least 2 or 3 miscarriages within like 4 or 5 attempts, something like that, where a female will try to get pregnant and multiple times succeed, but will lose the pregnancy. So habitual abortions can be caused by multiple things. One of the most simple causes, but one of the hardest to fix, is a retroverted uterus. Now we talked about how the uterus has to have that 90-degree angle over the bladder. The fact that it's an anterior angle, I guess, is important. Because of that angle, it allows for the support of the uterus, but it also makes it ideal for implantation. When the uterus, instead of being anteriorly folded, is folded posteriorly, that's called retroverted. That renders a female almost completely infertile, just because of the inability to maintain the fetus or the embryo in the uterine cavity. Now, another thing that can cause habitual abortions is cervical incompetence. So we've learned how the female has the cervix here. Cervix serves as the entrance to the uterine cavity. Now, if that cervix is not strong enough, it will not be able to support the fetus. And as you guys know, the fetus can get pretty large. So what can actually happen is once it starts to develop and grow in size, the placenta has yet to anchor the fetus to the uterus, so the weight gets too much and it will actually fall out. So it instigates delivery, not actual delivery, but that actually lets the fetus completely come out and cause habitual abortion. So one of the procedures we use to fix that is Sharaku McDonald. Sharaku is like the outdated version. It's not used anymore. That was very harsh and harmful. The new version is McDonald. And you can be asked about this procedure through its process. So I'm going to tell you guys how it works, just in case it's described, you guys can pick it out. With Sharaku McDonald, the cervix is actually stitched radially. So like if we had our cervix here, it's stitched radially, a lot like you'd expect to see a drawstring bag. And what's happened is the cervix is then pulled closed, secured by the stitching, and sewn shut. This will not allow the embryo to fall out of the uterus. It will allow it time to implant and grow enough to where the size of the fetus itself will hold it into the uterus. In which case, a week or 2 before delivery, maybe 3 weeks, these stitchings are removed and allowed to prepare for delivery of the infant. So that's Sharaku McDonald in case of cervical incompetence. What do we got now? Okay, almost an hour. Okay, so we talked about the uterus a little bit. And over here, let's see, 334. There's something else I want to show you. Oh, okay, there's no picture of it. Never mind, I thought there was a picture of it. Leiomyomas. Leiomyomas are the most common benign tumor of the ovaries. Benign means it will not affect the female in a negative way. However, and I want to show you this clinical point here. To show you, these are in the book. These are not. The non-neoplastic ovarian cyst, those can actually cause a lot of pain. And you can see it says here when the when ruptured, these follicular cysts are ruptured. And that is a lot similar to the way we actually release the egg. I'll show you a picture of that later on. I just wanted to make you aware of these. And PCOS, polycystic ovarian syndrome, that's a big hormonal imbalance. You won't be tested on this in this class, okay? There's too much of a hormonal part to play. That might be in endocrinology if you decide to take the class. There's also mentioned of something called a teratoma in your book. Teratomas, I think, are really cool. They aren't necessarily like of the ovaries. They can occur there. However, a teratoma is a mesodermal tumor. These are the ones where you can see different tissues exist within the tumor, like dental tissue, muscular tissue, skeletal tissue, connective tissue. And that has to do a lot because of the embryological layer of mesenchyme. It's called mesoderm. It actually remains undifferentiated and starts to grow. And since it's undifferentiated, it grows as everything it can, rather than what it's supposed to. So that's called a teratoma. Okay. See what I got here. Okay, cool. Now we're going to hit menstruation. Menstruation is a pretty good process to be familiar with. He might test you on the phases by what occurs in each phase. So we're going to cover the phases, the time periods, and what occurs in each phase. Menstruation. Okay, so menstruation is broken up into 3 phases. The first phase is called the phase of desquamation. And regeneration, right? Or is it proliferation? Yeah, regeneration. Desquamation and regeneration. What occurs in this phase is really important because progesterone will drop. There's a decreased level of progesterone. Progesterone is commonly regarded as the hormone that maintains pregnancy. So that will keep you pregnant once you are pregnant. Or if you take progesterone-based birth controls, it will actually trick your body into thinking you're pregnant to prevent you from menstruating. So progesterone decreases, meaning we're not pregnant. So estrogen will increase. Estrogen prepares those endometrial layers for pregnancy and implantation. So now we need to talk about what happens. But before we do, we need to know the time frame. So menstruation is about a 28-day cycle. And the first phase of desquamation occurs from days 1 to 4. Now it's important to know that day 1 is marked by the first sign of bleeding. Okay. So now what happens with our endometrial layers is that superficial layer. And we learn about our stratum compactum, stratum spongiosum. Sometimes those two together are referred to as stratum functionalis, which just means the functional layers. So the superficial, functional layers they're shed. Okay, awesome. So those functional layers are shed, and towards the beginning of this phase, begin to regenerate. All right. So this day 1 to day 4 is commonly seen because that's about the time period of the heavy bleeding, which takes us into our second phase, the phase of proliferation. So the phase of proliferation, we'll discuss the hormonal part, is estrogen dominated, meaning it's run by estrogen. We're going to prepare for implantation. It occurs in days, we pick up from where we left off, 5 to 15. Now, here we had before with desquamation, we begin to regenerate those layers. Here, we have the growth of the functional layers, meaning they'll actually begin to become larger than they were previously. And as part of that, we're going to see an increase in temperature by 1 degree centigrade, or Celsius. Typically, it's seen all over. Yeah, like if you go to your OBGYN to assess like your fertility, a lot of times they'll take your temperature to see if your average has increased. Yeah. This is an overall change in the body. Now, the really important thing is during this phase, we have ovulation. In your book, it's written in a pretty interesting way. So I'm just going to kind of go over that. It says 13 to 14 days before start of next menstrual, I think it refers to it as menstrual period, or menstrual bleeding. Basically, that means if we take our 28-day cycle, so here's day 1, here's day 28. If we do 28 and we subtract that 13 or 14, so minus 13 or 14, that puts us over here into day 14 or 15, which correlates to the exact end of the phase of proliferation. So ovulation can either be set as 13 or 14 days before the next menstrual cycle or during days 14 and 15. The wording can be kind of confusing, but I hope that helped make sense of it. And that marks with the end of proliferation phase. As long as you remember the days of proliferation phase, you should be able to remember the days of ovulation as just the last 2 days. Okay. So going to our third phase, we have the phase of secretion, or the secretory phase. So we have another hormonal switch. We have this one being progesterone dominated. Okay. So remember I said progesterone is meant to maintain pregnancy. So here at the end we have ovulation. The body is waiting for implant. That's why progesterone is dominating the last phase. To also prepare for implantation, we have increased mucus secretion, increased arterial growth in that functional layer, and now at the end of this phase, we're going to transition to our first phase again, where we said, if you guys remember here, progesterone decreases. It almost completely goes away. So the progesterone decreasing will lead to ischemia. If you guys remembered what ischemia means from our other blocks, it means lack of blood supply. So basically what that means is all those arteries that were grown in the uterus now begin to shrivel. If you guys can see this picture right here, these are referred to as spiral arteries. Those begin to lose blood supply. And when estrogen begins to dominate in that first phase of desquamation, that will force them to dilate even though they're trying to wither away. And that will actually lead to those first apical layers being shed and those arteries being ruptured and causing the bleeding. So that's what actually causes that landmark for that first day of menstruation, is the shift between progesterone and estrogen causing the rupture of those spiral arteries. And you can see right here, those arteries are really, really predominant in this thick endometrial layer. You begin to bleed and have that ischemic bleed out. The layer itself dies and gets shed, and then here you have it all happen again. Okay. So that's all I've got for menstruation. We're going to shift back over and cover some of the male portion. So what we're going to cover now is the layers of the scrotum. So scrotum is the skin that actually holds the testicles. We talked about how those testicles begin descending. We're still talking about the testes, so we can still be asked those questions. So as a review, testes begin begin descent on the 7th week of intrauterine life. It talks about the testes receiving the signal to descend at about the 6th week. The descension itself begins on the 7th week. It makes it a little easier to remember because we just remember 7, 7. 7, they begin, and by the 7th month, they should be fully descended. Now, Dr. Samson talks a lot about how they bring their luggage with them and all that good stuff. So now we're actually going to talk about some of that luggage. We're going to start superficially, which means more outside. Superficial, more towards the surface. We have 6 layers. The first layer is skin. So far, so good, right? First layer is skin. Next layer we have is called the dartos fascia, also accompanied by a muscle. Dartos fascia and muscle. Our third layer is the external spermatic fascia. Okay, good. 4, we have the cremaster muscle. That's also coming back from the last block. Our next branch, if we have an external spermatic fascia, we have an internal spermatic fascia. And if you guys remember our gemellus sandwich from block 1, this is a new sandwich. We have the cremaster sandwich. And the 6th would be the tunica vaginalis. Not to be confused with processus vaginalis, but we'll get to that in a little bit. See, I almost did it, so it's an easy mistake to make. So a good thing to know is not only what is there, but where it comes from. So we had actually discussed in the past cremaster muscle's origin. Do you guys remember what cremaster muscle originates from? Okay, cool. So it originates from the internal abdominal, this is supposed to be an A, oblique muscle. So we'll start from the beginning. Skin comes from skin. That's a pretty easy one. That one's good. Dartos fascia, not as exciting. It just comes from the superficial fascia underneath the skin. Do you guys know the function of dartos fascia? Awesome. It's a thermoregulator. I like those words. Because remember, we began the descent of the testes to escape the heat of the abdominal cavity. So it would make sense that they have their own way to regulate the temperature. So if it's too cold, dartos fascia and dartos muscle can actually constrict and cause the skin of the testes to shrivel. That will work to insulate heat. If it's too hot, it'll relax and allow the tissue to kind of expand. That will dissipate more heat. So dartos fascia is important for that reason. It's a thermoregulator. External, external. External, abdominal, oblique. So you have the externals paired together. This is where a lot of people get messed up because they want to say, oh, external goes to external, internal goes to internal. Doesn't work like that. We have our cremaster sandwich right in the middle. So internal abdominal oblique will lead to the cremaster muscle. But the internal spermatic fascia is formed by an extension of the transversalis fascia. And the tunica vaginalis is an extension of the peritoneum. Because in males, the peritoneal cavity is closed. So when the testes begin to descend, it pulls the layers of the peritoneum with it. Okay, cool. So we've covered our layers. Now I want to cover some pathologies. And I lost my markers. Okay. So here we have a testy. On the posterior portion of the testy, you guys might remember from lab, you have the epididymis, and it does all the good things the epididymis does. But now we're looking here. So vas deferens, we have this structure coming in, our spermatic cord. So here we have our processus and our tunica vaginalis. So I'm going to label these as our testes. This is our epididymis. All right. Now, this closed portion up here is the processus vaginalis. And this one's probably my favorite of the two, the tunica vaginalis. I always remember these two because the tunica vaginalis is dilated. Or you can also say that the layers of the peritoneum are not closed. However, with the processus vaginalis, if you guys remember, the peritoneal layers that make up that processus vaginalis must be closed. I remember that one because it looks like the testes wearing a tunic. The tunica vaginalis. Okay. So, we know our peritoneum secretes synovial fluid or serous fluid. Actually, that's a better word. Serous fluid. So it's a serous membrane. And if this is an extension of our peritoneum, it is also a serous membrane secreting serous fluid. So just like with our peritoneum and excretion of extra secretion, that can happen down here. So if the processus vaginalis remains open, that's called patent. Oh, I spelled that wrong. Patent processus vaginalis. Basically, that means that this processus vaginalis, rather than being closed, is open. And that means that excess fluid will build up in that cavity, potentially compressing the surrounding structures, like we talked about, the testicular artery and vein, cutting off blood supply. Could render someone infertile if it goes long enough unnoticed. You can have referred pain. We discussed referred pain of the genital area usually refers to about L1, L2, so down the inner thigh in the inguinal region. So that's good to know. Along with compressing the vas deferens. If you compress the vas deferens and inhibit these, I guess you could just say the sperm from exiting the epididymis, that's another way to cause infertility. It's the same way as when you do a vasectomy. You cut the vas deferens. This is just a blockage. It's compressed closed. Another thing that it can cause, which I'll put here in green, it's called hydrocele. Yeah, this is also from patent processus vaginalis. So this is hydrocele of the cord. Now, as you can see up in this area, we would be in our spermatic cord. And that's why these structures get compressed. I don't know if you guys remember, but we discussed how narrow the spermatic cord actually is, to the fact where if a loop of hernia is in, if a loop of intestine there is herniated into the spermatic cord, it will compress all these structures as well. So that's hydrocele of the cord. And that's up here. So I'm going to switch colors. We're going to go to purple. And I'm going to talk to you guys about something similar. And that's called hydrocele of the testes. And that's when there's oversecretion of these serous fluids into the tunica vaginalis. Now, much like the patent processus vaginalis, this can compress the testicles themselves, cause a lot of the same things as far as infertility goes. It's less severe, more so aesthetic, uncomfortable. The testes seem enlarged, but it's just that dilated tunica vaginalis full of fluid. One other form you can see this in is called hematocele of the testes. Now, I don't know if you guys remember what the precursor hema means, or hemato. It refers to blood, like we discussed hematopoiesis. So this would be hematocele of the testes, meaning that blood has filled this tunica vaginalis and is now causing it to swell and dilate. So one common procedure when a patient has enlarged testicles would be to actually shine a flashlight underneath, much like your fingernail. If you shine a light through, it's kind of pinkish, right? Yeah, it's kind of pinkish. That's because of the blood. Now, that's normal vasculature. So when our vasculature is normal, in the case of, I'll use orange. In the case of hydrocele of the testes, so hydrocele with light will appear pinkish. Will appear pinkish, much like your finger. However, when you have hematocell with light. It's dark. That concentration of blood is much higher. Blood is a very dark, viscous fluid, so that actually blocks a lot of the light. And that's a good way to tell whether it's blood through some arterial rupture or some other pathological condition, or simply an excess of serous fluid. Okay. How much time we got? A little less than an hour. Okay, good. So we're going to see if we can speed this up just a little bit. We're getting close to what I want to discuss on Chapter 5. So this is our last topic for Chapter 5. I got a question about if the videos that I've posted have overlap. They do have a significant amount of overlap as far as what topics are covered. Like I said, the topics are in varying depths. I'm not covering some things that are important because I covered them recently in videos before. So make sure to watch those videos. Pace yourself, though, they're long. Okay. So we're going to discuss erection, emission, and ejaculation. Okay. So first we're going to discuss how the nervous systems mediate these processes. So with the erection is a parasympathetic phenomenon. That means your parasympathetic system is responsible for causing the erection. And moving down the line, emission. Emission is when the sperm and the semen begin to move up towards the ejaculatory ducts in the prostate, preparing for ejaculation. This is controlled by the sympathetic system. Now, ejaculation is awesome. Ejaculation is a mix, not only of parasympathetic, not only of parasympathetic and sympathetic, but also somatic nerves. And in this case, pudendal is the example. So this is parasympathetic. I'm going to make that a bracket. Okay, so now we'll talk about what happens. So with the erection, we actually have, as you guys know, the arterial dilation. So we have increased, I should have used a different color, increased blood supply. But what actually causes the erection to occur, so I'm going to put a star with that, is venous constriction. So what's actually going to happen, and I want to show you guys this picture right here. If you guys remember the cross-section of the penis picture, we have that superficial and deep dorsal penile vein, and with the arteries providing a little bit extra blood supply, and the veins constricting to limit its exit, that pressure increases. It's the same way we had our portal hypertension from liver cirrhosis, our systemic hypertension from coarctation of aorta, or just from atherosclerosis and stuff like that. So what's going to happen is increased blood flow, but because of the constriction of some of these muscles around the area and these veins, the blood will actually get stuck in this area and cause the corpus cavernosum to swell and this dorsal penile vein to swell. And that'll give it the rigidity. So erection is caused by venous constriction, less arterial dilation. So emission, like we discussed, was the sperm, sure, we'll be specific, prostatic secretion, and seminal vesicle secretion. Arriving at ejaculatory duct in the prostate. Now, when you have the sperm, the acidic prostatic secretion, and the basic seminal vesicle secretion, seminal vesicle? Yeah, okay. So the seminal vesicle secretion, not to be mixed up with seminal colliculus. That's what I just did. So as a reminder, if you guys don't remember from lab, the structure on the posterior aspect of the bladder is the seminal vesicle, while the portion inside the prostate is the seminal colliculus. So all those contents arriving to the ejaculatory duct in the seminal colliculus is referred to as semen. So there's a difference between sperm and semen. So that's the preparation for the ejaculation. Now we get to the ejaculation, we can talk about how it's a mixed function. So we talked about with our bladder the different sphincters, right? So we had our internal sphincter controlled by the sympathetic system. We want that to be closed to prevent any retroflow into like the pre-prostatic urethra, causing a urinary tract infection or a bladder infection. So sympathetic will close internal urethral sphincter. While with parasympathetic, we can have the erection and the somatic. This is the good stuff. Somatic, the pudendal nerve, will actually contract the bulbourethral muscle to cause or to provide the pressure for ejaculation. So this provides the erection. Parasympathetic has some other minor functions too. It's more important to know these two, in my opinion, because this will actually prevent retroflow, which prevents further infections. And this is the actual mechanism. The part that a lot of people overlook is that there is somatic innervation involved in ejaculation. Okay. So that's the last topic I wanted to cover for chapter 5. If you guys happen to miss anything, I'm going to take my papers outside so you can take pictures of them if you just want to have a picture. Because we got to get out and make sure that other people have time to prepare for their sessions. So next, I'm moving towards the topics of chapter 10. Kind of going to cover those as quick as possible. One of the biggest things for chapter 10 is a picture. So that picture is on page 614 in the 3rd edition, figure 10-41. That's a picture of the cerebellum. Yeah, page 614, figure 10-41 is this picture of the cerebellum right here. It's important to take with the fact that the cerebellum has 9 lobules. So let me see if I can write that up in here somewhere. Okay. So cerebellum has 9 lobules. Now they're labeled in your book, so it's really good that they are. Work on memorizing them. Typically, we start from the superior anterior portion, which is about right here, and we go counterclockwise. So my little trick to remember this in the past was just a series of letters. So we have LC, CD, FT, pun. I kind of like the way it sounds. LC, CD, FT, pun. If you can remember this, and what they stand for, you're good with the function, or with the cerebellum. There's not much we need to know about it except labeling it. Yeah?
So even though we're only supposed to know the first 20 pages of the chapter, we have to know this one even though that's something?
Correct, yeah, because usually he'll specify the first 25 pages and the picture of the cerebellum, because he wants you guys to be familiar with it for later on. If you guys take any other advanced classes, that you will be aware of its like position and function. Good questions. So starting from the anterior superior portion, about it right here, you have the lingula, central lobule, the colon, the declive, D-E-C-L-I-V-E, the folia, or the folium, it's more accurate, the tuber, the pyramid, the uvula, and the nodule. I cover this in a little more detail in another video. I just wanted to expose you guys to what this is in case you do decide to watch it. You're not surprised. And if you don't, you at least have this to work with. There's a couple other things about the cerebellum that I want to hit. Very few. The cerebellum is actually meant to coordinate fine movements. So the ability to put like extension with rotation, with flexion, to do a simple action like picking up a cup, that's coordinated by the cerebellum. It's like the traffic cop. So the cerebellum coordinates fine movement, and when you have injury to the cerebellum, oh, yeah, sure, that's really zoomed in too. Okay. So when you have injury of the cerebellum, you have something that's called intention tremor. There are some things he'll pick out that's not in the book that he likes to question on because he talks about it. This basically means if you're lying still at rest, you're fine. With a cerebellar injury, when you pick up your hand with the intention of doing something, when it tries to coordinate those movements, it can't. So you have someone that'll start shaking. It's different from Parkinson's, where you have resting tremor, where no matter what they're trying to do when they're at rest, they shake. This is different in the fact that you have to make an intentional movement. So that's why it's called intention tremor.
Does it say coordinates
Fine.
Fine.
Yes, like smooth. Smooth movements. Okay. So another random thing to pick out from his lecture that he may test on, it's not likely, but when he gave you the brain and all those numbers that did different things, those are not relevant for this class. There's one that he mentions often that he likes to test on sometimes, and it's an important introduction. Those areas, those numbers are called Brodmann's areas. The only one you guys might be responsible for knowing is area number 4. And you guys had labs, so you guys should be aware of the areas I'm going to talk about. Area 4 is the pre-central gyrus and is responsible for the pre-motor signals. So before you even do something, area 4 is activated to give your body that signal when you need it. Which is why, I don't know if you've heard of the experiment where people will ask someone to press a button whenever they want, and they'll put wires on their brain, and the brain shows activity before the person even really thinks about doing it because of that premotor area. Does that kind of make sense? Okay. But that's the extent you'll need to know from the stuff he lectured on. However, straight from chapter 10, you'll need to know those first 25 pages. The biggest topics to know are the glial cells. I'll try to go through this quick. So the glial cells, the mnemonic we like to use is SS omega. So basically, this just divides the glial cells by the peripheral nervous system and by the central nervous system. So we'll run through the names really quick, give them a function and special attributes, and then we'll move on. So for the peripheral nervous system giving us our SS, we have our Schwann cells, and we have our satellite cells. Schwann cells serve to myelinate. That's the extent of what you need to know. They myelate the peripheral nervous system. Satellite cells are support cells. They basically serve to take up space and provide physical support to the nerve cells and the axons. We discussed previously that no space in the body is actually empty. It's either filled with that loose areolar tissue, if it's a somatic system, like skeletal muscle or like vascular system. But when it's the nervous system, it's filled with satellite or astrocyte cells. So satellite in the peripheral and astrocyte in the central nervous system. Now, astrocyte is a little more special, I guess. It provides support, but also regulates the biochemical environment. This meaning a lot of neurotransmitters, some signaling proteins. One other thing that it does is regulate concentration of potassium. Potassium is essential for nerves to send signals. If we don't get to it, because we only have like 15 minutes left, 20 minutes left, read over the action potentials and how the nerves actually send signals. I'm dying. Okay. So that's astrocytes. This G is in parentheses just because it stands for glia. There is no glial cell that starts with G. That's just to make the mnemonic work and to remind us we're talking about glial cells. Glial cells are the non-excitatory cells in the nervous system. They have other functions besides sending electrical or chemical impulses to have an effect. So then we have our ependymal cells, E-P-E-N-D-Y-M-A-L, ependymal cells. You can also say ependymal, however you want to. Ependymal cells mostly serve to line the ventricles and the central gray column in the spinal cord. Oh, one other thing I forgot to add about astrocytes is they comprise most of the blood-brain barrier. The likelihood that that'll get tested is pretty low, but it's important to know because astrocytes are some of the most important support nerves. The M then stands for microglia. Microglia. Microglia are the immune cells of the central nervous system. They act as macrophages. If any of you guys have taken immunology, you learned that you not only had macrophages, but you have microphages. And that's a good way to remember microglia. They're a lot similar to macro or microphages. Okay, and O, the very important oligodendrocyte. Oligodendrocyte, I'm going to have to put the function up here. Myelinates the central nervous system. There are other things it does that might be specified in your book. However, they're beyond the scope of this class. Like they send chemical signals. That actually inhibit the growth of neurons. It sounds counterintuitive, right? Now, with oligodendrocytes, they myelinate the central nervous system so quickly, they can myelinate up to, I think, like 10 to 60 nerves at once per cell. And the central nervous system is not fully myelinated until a child is about 2 years old. That's kind of why babies have really slow reflexes or like they're kind of derpy. It's because that central nervous system isn't fully myelinated to give them the proper coordination that we have as adults. And that's because myelin actually stops axon growth. And that has to do with the function of oligodendrocytes, but that's beyond the scope of this class. As long as you know that they myelinate and they can send chemical signals for growth mediation, you're good. Okay, we got a couple minutes left. That's all I wanted to add for this. One more thing to know structurally. Not much is going to be asked of you structurally about a neuron. However, it might be important to know that on a neuron that's myelinated, and this is a very horrible neuron. This is the body. This is the terminal. These gaps right here are called nodes of Ranvier. So nodes of Ranvier are gaps in axon myelin. And you guys remember myelin actually serves to propagate nerve signals or speed them up. You guys ready? Okay. So talking about the speed of nerve signals, we have some categories and some subcategories. We have A nerves. Sorry. A, B, and C nerves. So A has some further subtypes. A alpha, A beta, A gamma, oh, I done screwed up, and A delta. So basically, A nerve fibers are very large nerve fibers that are also myelinated. The diameter of a nerve fiber, the nerve axon, makes it go faster. It's a lot like I-4. If I-4 were to only be one lane each way, it would be extremely slow. Diameter, you increase how many lanes you have, you increase the speed of the nerve signal. That's why we talk about large diameter, and myelin serves to increase the speed of a nerve signal. So then you have alpha, beta, gamma, delta, and as you go down, they get slower. These are still regarded as the fastest nerve fibers you have, but this is the order in decreasing speed. You could be asked, what is the proper order from fastest to slowest? Which of the following is faster than an A beta? And the only thing faster than A beta is A alpha. So that's how you can see these questions. B has a thin axon. However, it's still myelinated. And C, those are the slowest nerve fibers. They're usually used for chronic or dull pains, throbbing pains. They are thin and unmyelinated. Okay. So we don't have much time. So like I said, read over the way nerves send signals. That's called action potential. That's also in those first 25 pages of chapter 10. And what I actually want to do is talk to you guys about the pictures. He tells you guys a lot of pictures that are going to be on this exam. However, you can't guarantee that every single one will be. So the best way to go about it is to study them all. They're pretty simple pictures. So I'm actually going to write down what pages they're on so you guys can have them all with you. And separate them by topic. So referring to the oral cavity, I guess we'll picks. For the oral cavity, there's one on page 555, which is the oral cavity proper. There's also one page on page 569, which is the posterior view of the pharynx or the pharyngeal region. When you look at these, make sure you look at Waldeyer's ring of lymphoid tissue. Be able to recognize where all the different lymphoid organs are in that picture. Okay. Moving on, we have a picture relating to the optic system, and that would be on page 661. I wanted to go through these, but we don't have time. That would be layers of the retina. So, bless you. As far as the retina goes, you have about 6 functional layers. There is 661. There's 2 pictures. One of them is the one that's more likely to be on your exam than the other one. So I'll show it to you really quick. It's this one. You can be asked on both. However, if you know this one, which is I think easier to remember, this one is exactly the same. And also try to relate the names to what the layers look like. The names are given for a specific reason. For the inner plexiform layer, it's all these synaptic plexes. And remember, this vitreous humor is the inside of the eye, which is why inner may look like it's more superficial and outer may look like it's deeper, but it's backwards. Because while the eye is like this refers to inner, and this is outer. So going out. Does that kind of make sense? Okay. Because this is taken as though it were cut from here. As vitreous humor is a good landmark for that. Okay. Layers of the retina, that's a pretty popular one. Okay. So then you have the tympanic membrane. Tympanic membrane is on page 668. Dig back in your notes. Review what happens with the cone of light during otitis media. Otitis media being fluid buildup in the inner or middle ear, pushing out the tympanic membrane. I'll review with you now really quick. That's, the cone of light is supposed to be in the right lower quadrant when you're looking at it with an otoscope. It's the little thing with the light that you look in an ear. If that cone of light is not in the right lower quadrant, there is something wrong. There is increased pressure in the inner ear cavity, either due to an infection, otitis media, or something else being present in the middle ear. Okay. Okay, so those should be all the pictures that we haven't already covered. From chapter 5, you might need to know the cross-section of the penis we looked at. And you might need to know female what's up? Yeah, I can look really quick. Or female external genitalia. I don't have those written down because I already went over them slightly. But those are in chapter 5. While I have a couple minutes left, I actually want to cover the oral pigmentations. So I'll try to do both at the same time. Okay. So oral pigmentation can be caused by 3 different things. The first one we discussed is called Peutz-Jeghers. Peutz Jeghers, Peutz-Jeghers. That one's not typically tested on just because we don't cover it too much in detail. That one is a clinical point in your book. I just wanted you guys to make aware of it. One of the ones that he will test you guys on more likely will be Addison's disease. So Addison's disease is caused by excess ACTH, which is adrenocorticotropic hormone. Okay. And the final way that we most commonly see oral pigmentation is heavy metal poisoning. A lot of times Dr. Sampson will talk about, like, if you have an unfaithful husband who spontaneously gets like a silverish color in the lining of the gingiva. Yeah, no, I'm gonna stop there. I'm sure you guys can figure out the rest. A lot of times that's on accident because you may not know something's contaminated, or it's criminal offense, as in like rat poison and stuff like that. That happens kind of often. So those are the three ways you'll see oral pigmentation. And okay, a couple other things real quick. Cover the tongue. Tongue is broken up into three areas. We have the anterior 2/3, posterior 1/3, very back. We need to know how the tongue serves its function. Okay, so for the anterior 1/3, we have innervations by cranial nerve 5 and cranial nerve 7. Cranial nerve 5 is trigeminal, so I say cranial nerve 5, trigeminal, general. General sensory innervation, meaning just touch. The fact that you can feel things with your tongue, that you can feel that they're hot, is due to trigeminal nerve. Cranial nerve 7, special. Special sense being taste. From now on, it gets really easy. Cranial nerve 9 in the posterior 1/3 does both. And in the very back, cranial nerve 10 does both. And it's important to review these because we have the pharyngeal plexus. Pharyngeal plexus comprised of cranial nerve 9, 10, and parts of 11. 9 is our sensory portion, and 10 and 11 are our motor. 10 is main motor. 10 is main motor. Okay, so we got like about 3 minutes to wrap this up. I will tell you guys, for the pharyngeal plexus, remember the gag reflex, which is why I added sensory and motor. Much like our other reflexes, you have to have something to pick up the sensory stimulus, which would be cranial nerve 9, and a motor effector limb, which would be 10 and 11. And some other random infectious things that we talked about at the end of the last lecture. I lost a marker. Here we go. Some of those include measles, also called rubeola, not rubella, rubeola. That's characterized by Koplik's spots, which are red outside, white inside, as in this center. It looks like a target. So out here is red, in the middle is white. Another good important one to know is mumps. Mumps, the mumps virus, will infect the parotid gland. And that can actually compress cranial nerve 7, which can then lead to Bell's palsy. Okay, which takes me to the very last thing I want to talk to you guys about, which would be salivary gland innervation. So we have parotid. We have parotid and sublingual and submandibular. Now, we also have salivary nuclei. And the way this works is between cranial nerve 7 and cranial nerve 9. So cranial nerve 7 position is superior to 9, right? So 7 is a superior salivatory nucleus, while 9 is the inferior salivatory nucleus. If you ever forget, just remember 7 superior, the SS. SS carries in a lot of places. So 7 superior salivatory nucleus will actually provide innervation. Did I do that backwards? No, that's right. To the parotid gland. And then we have the inferior salivatory nucleus to the other ones. Okay, so that was the last thing. Possibility of you being tested on that is pretty okay. It's something he'll usually like. Read about it in your book. It gives a little more detail that I don't have time to go over. But great session, guys. I hope it was helpful. It was definitely a good last review for me. So if you guys miss anything, I'll be outside. Just please make sure you don't leave any trash. And I hope you guys have a good test.